This is Goldie Khanna on behalf of authors Dr. Pasculi, Dr. Barker, and Dr. Farrell, giving a presentation of our chapter on postoperative infections of the head and brain. This talk will discuss the etiology and incidence of postcraniotomy infections, the various clinical and radiographic findings to aid in diagnosis, and an overview of the various treatment paradigms of effective therapy. The diagnosis of infection after craniotomy is often challenging. An accurate understanding of the clinical, laboratory, and radiographic manifestations of postcraniotomy infection is critical to enable timely medical and surgical intervention and to limit the neurological sequelae of infection. Host defense mechanisms, which represent the primary barrier to the establishment of infection, may be impaired in patients undergoing craniotomy. The brain is a relatively immune-privileged site, and low levels of antibody and complement factors contribute to make the brain less efficient than other organs of the body at eradicating infection. As such, early and decisive intervention is necessary to curtail the morbidity associated with postoperative infections. The cornerstone of successful treatment of postcraniotomy infections is effective source control, identification of the pathogens, and prompt initiation of an appropriate antibiotic regimen. Given the wide-ranging manifestation of postoperative infections and the various underlying patient-specific factors that influence treatment choice, close cooperation between neurosurgeons, infectious disease specialists, and hospital infection control services is critical. Several large prospective studies have been reported regarding the incidence of postcraniotomy infection rates, which range from 1% to 10%, with the higher rates occurring in the absence of antibiotic prophylaxis. In their 10-year retrospective study that included a cohort of over 16,000 patients who underwent craniotomy at the Barrow Neurological Institute, Dashty et al. Reported an overall incidence of 0.5% of postoperative infections that required return to the operating room for debridement and evacuation. Infections after craniotomy are most commonly associated with gram-positive bacteria such as Staph aureus and coagulase-negative staphylococci. Cutibacterium acnes is a commensal skin flora that has been established as the causative agent in various infections and typically manifests in a more indolent clinical course compared to other pathogens. Gram-negative bacteria have been isolated in 5 to 8% of postcraniotomy infections and are often present within polymicrobial infections. Gram-negative species are often the causative agents found in postcraniotomy cerebral abscesses. Although it is unlikely that all postoperative infections can be completely prevented, many of the factors influencing the development of infection may be modifiable, particularly those attributable to the patient and others related to the surgical intervention itself. Patient comorbidities such as obesity, diabetes, tobacco use, and advanced age have all been shown to confer an increased risk of infection. Furthermore, patients who are undergoing craniotomy inherently often have impaired host defense mechanisms. For example, patients with malignant gliomas express a variety of immune defects, including increased secretion of immunosuppressive cytokines. Various factors pertaining to surgery itself have been shown to increase the risk of postoperative infections, such as CSF leak, prolonged surgical times greater than 4 hours, a concurrent infection in another organ system, and the implantation of foreign bodies. Perioperative management of patients' medical comorbidities is crucial in mitigating the risk of postoperative infections. Diabetic patients should have tight glycemic control perioperatively. All patients should receive proper nutrition. One study showed that as few as 5 days of enteral nutrition help confer a decrease in risk of infection compared to patients who are otherwise malnourished. In the operating room, the use of clippers as opposed to razors has been shown to decrease the risk of infection, owing to the inoculation of tiny abrasions that inevitably happen when using a razor. However, other measures that are commonly used, such as the use of adhesive barrier drapes and preoperative bathing using an antiseptic skin product, have not been shown to decrease the risk of postoperative infection definitively. Of course, it is imperative that the operating room is properly cleaned and disinfected in order to decrease the bacterial burden in the room and the rate of pathogen transmission within the OR. Administration of perioperative antibiotics has been shown to play a crucial role in reducing the incidence of postcraniotomy infections. The Surgical Care Improvement Project provides 3 overarching guidelines in regards to the perioperative antibiotics. 1, the selection of an appropriate antibiotic. 2, its administration within 1 hour of a skin incision with intraoperative redosing as needed. And 3, discontinuation of antibiotics within 24 hours after surgery. In most cases, ANSEF is used as standard surgical prophylaxis. In patients with documented MRSA colonization, vancomycin may be used instead. There have been a few small case series investigating the use of topical antibiotics at the craniotomy site, which have shown promise. However, its use must be weighed against the potential for an increased incidence of gram-negative infections, as well as consideration that this may potentiate the formation of multi-drug-resistant species. Postcraniotomy infections can be categorized based on the location where the infection occurs. The CDC defines superficial incisional infections as those limited to the skin and subcutaneous tissue, whereas deep incisional infections may involve the subgaleal space and the bone flap. Deep organ space infections include subdural empyema, Brame abscesses, and meningitis ventriculitis. First, we will discuss superficial incisional infections, which represents the most common infectious complication after craniotomy. Superficial infections occur at the skin and subcutaneous tissues. Presenting signs include skin erythema, induration, and tenderness to touch at the incision site. Exposed hardware can occur months to years after surgery and is often a sequelae of a chronic indolent infection. The majority of superficial incisional infections are caused by commensal gram-positive skin flora such as Staph aureus, Staph epidermis, and Cutibacterium acnes. Most infections that are isolated to the superficial skin can be treated with antibiotics alone. However, wounds that are poorly healing and those that do not show good approximation may require debridement and wound revision in the operating room. In patients with difficult to treat, poorly healing wounds, hyperbaric oxygen has been shown promise in helping these incisions heal. However, in patients with large defects that cannot be repaired primarily, local rotational flaps or vascularized myocutaneous free flaps may be necessary. Next, we will discuss deep incisional infections. Deep incisional infections can be due to direct bacterial spread from the more superficial layers or extension of infection from the adjacent subgaleal or epidural compartment from inoculation at the time of surgery. Development of infection within the devascularized bone flap presents increased challenges for treatment, and any superficial infection extending to the subgaleal space must be presumed to have contaminated the bone flap. In this photo, you can see spread of infection to the underlying bone flap with erosion and adjacent purulent material in the epidural space. The figure on the right shows gross contamination of the undersurface of the devascularized bone flap. A high index of suspicion is necessary to diagnose bone flap infection because laboratory markers and imaging findings are often nonspecific. Most patients have a normal white count upon presentation, and only about a third of patients present with elevated inflammatory biomarkers. CT and MRI studies may show the presence of subgaleal or epidural infection with bone flap destructive suggestive of osteomyelitis. Hardware failure with surrounding bone lucency may also indicate infection. Devitalization and devascularization of the bone flap at the time of craniotomy presents a unique challenge in the treatment of infection because of impaired delivery of host defense mechanisms and antibacterial agents. Certain small case series have shown that the bone flap can be salvaged in patients with deep incisional infections through mechanical debridement of the bone flap and soaking it in antibiotic-containing solution at the time of surgery. Although it is important to note that these patients were kept on antibiotics for a prolonged period of time. In another study, Kashetri et al. Showed that removal of the bone flap with replacement with titanium mesh cranioplasty is feasible, although, again, these patients were treated with 4 to 6 weeks of antibiotics followed by PO suppressive therapy. As such, the most efficacious way of definitively eradicating a deep incisional infection is with removal of the bone flap, followed by a course of antibiotic treatment and subsequent cranioplasty at a later date. However, in the selection of the therapeutic approach for each patient, the risks associated with salvaging the bone flap and preventing a cranial defect must be weighed against the hazards of the infection itself, as well as of prolonged antibiotic administration. The last category is deep organ space infections, which occurs in the epidural space and deep to it, and is comprised of subdural empyema, intraparenchymal brain abscesses, and meningitis ventriculitis. Subdural empyema can present in a delayed fashion compared to superficial incisional infections, and post-craniotomy subdural empyemas often have a more indolent clinical presentation than spontaneous empyemas. Patients can present with seizures, and diffuse encephalopathy is very common. Systemic signs of infection, such as fevers, chills, headaches, are only present in a small portion of patients who harbor subdural empyemas. Because lab values are nonspecific in diagnosing postoperative subdural empyema, imaging plays a crucial role in its diagnosis. MRI typically shows an extraaxial fluid collection that appears relatively isointense to CSF, albeit it exhibits signal suppression on flare sequences. Subdural empyemas often show peripheral enhancement on post-contrast sequences and classically diffusion restrict, although the absence of these radiographic features cannot entirely rule out infection, especially early in the clinical course. As such, a high degree of clinical suspicion must be maintained when reviewing the clinical, laboratory, and radiographic signs during patients' workup. This is an illustrative case of a patient who presented about a month after undergoing a right frontal craniotomy for resection of a GBM. You can see the presence of a right-sided convexity extraaxial collection with suppression on flare sequence. The collection exhibits peripheral enhancement and marked diffusion restriction. Surgical evacuation of the empyema is imperative to prevent further intraparenchymal spread, with resultant thrombophlebitis and possible venous infarction. Although the optimal surgical approach, craniotomy versus burr hole drainage, is debated, craniotomy is generally advocated because it ensures maximal drainage of the collection and allows for inspection of the adjacent anatomic areas and removal of the bone flap if necessary. Patients should be promptly started on broad-spectrum antibiotics, which can be narrowed once culture speciate and sensitivities are determined. Intravenous antibiotics are often administered for 4 to 6 weeks and possibly followed by PO suppression. Although the incidence of brain abscess is rare after craniotomy, it is fraught with morbidity. Once infection has been established in the brain parenchyma, abscess development begins as a localized area of cerebritis, characterized by perivascular inflammation and edema formation. It then progresses to a discrete focus of necrotic purulent material surrounded by a well-vascularized capsule comprised of fibroblast and reactive collagen. The most feared complication of a brain abscess is its rupture into the ventricles. Although patients with brain abscesses have various clinical symptoms upon presentation, rupture into the ventricle typically causes sudden neurological deterioration with obtundation or coma. Intraventricular rupture of abscess is associated with poor neurological outcomes, with case series reporting rates of coma and death as high as 50 to 85%. On imaging, brain abscesses are characterized by an intraparenchymal lesion that shows peripheral enhancement and possibly central diffusion restriction. The closer the proximity of the abscess is to the ventricle, This portends a higher risk of rupture and introduces purulent content into the CSF circulation. Once brain abscess has been diagnosed, its content must be drained. This can be done via an open craniotomy or via stereotactic aspiration. Broad-spectrum antibiotics should be initiated promptly, including empiric coverage of anaerobic organisms. Brain abscesses associated with intraventricular rupture may also require more aggressive treatment to reduce morbidity and mortality. Intrathecal administration of antibiotics can be considered in patients who are refractory to treatment with IV antibiotics or those who fail to achieve therapeutic antibiotic concentrations in CSF. There are currently no large-scale studies for treatment guidelines for the appropriate indications or duration of intrathecal antibiotic administration, and this form of therapy should only be considered on a case-by-case basis. Endoscopic ventricular lavage is a therapeutic option in patients with persistent heavy bacterial burden in the ventricles, or in patients with ventricular scarring and adhesions, which can impair cerebrospinal fluid clearance and limit the ability of antibiotics to penetrate these spaces, making these infections refractory to IV treatment. Bacterial meningitis is a relatively uncommon postoperative sequelae. Unfortunately, however, differentiation between chemical and bacterial meningitis is frequently problematic, and no single clinical sign or diagnostic test distinguishes between the two entities with complete certainty. Culture of cerebrospinal fluid is the gold standard for the diagnosis of bacterial meningitis, although one must exert caution that gram stain is highly insensitive for diagnosing infection. CSF white blood cell counts greater than 7,500 and glucose concentration of less than 10 is highly suggestive, however, of bacterial meningitis as opposed to aseptic meningitis. CSF lactate and IL-1 beta are other useful adjuncts in distinguishing between the two entities as well. In conclusion, although the overall incidence of postcraniotomy infections is low, in the order of 1 to 5% in most published case series, timely identification of infection and prompt initiation of treatment is imperative. Superficial infections can often be treated with antibiotics alone, but deeper-seated infections, particularly those that involve the bone flap, require surgical debridement and evacuation, followed by prolonged IV antibiotic treatment. The treatment of postoperative infections requires collaboration amongst a multidisciplinary team in order to achieve the best clinical outcomes.